Good morning, everyone. So some of you I know, and I just have to ask, just for my own interest, how many of you have a catheterizable stoma? Okay, so you're putting a catheter into the stoma to get the urine out, so an Indiana pouch type of procedure, so about 2. How many of you have a neobladder? Okay, so a couple. And how many have a urinary diversion, which is the conduit with the pouch on the outside? Okay, so we have a few more of that patient population. Okay, so what I'm going to do is we're going to talk about strategies to manage leakage. I could talk on each of these separate surgeries probably for an hour. We have 30 minutes, so I may talk a little fast, but I will be here for the rest of the day if you have any specific questions you want to ask me. And we are going to talk about the 3 types of surgeries because I wanted to make sure that I was inclusive to the audience that was here today. So what we're going to do is discuss the possible reasons for urinary leakage following urinary diversion surgery and to identify some strategies that may help to improve or resolve urine leakage. So I just want to start off by saying that a few years back, myself and the colleagues that are mentioned on the slide participated in a research study that really wanted to look at the experiences of patients having radical cystectomies for bladder cancer, and to really understand what the experience was of those patients involved in the study. And we were hoping that we were going to be able to include all 3 types of diversions because that had not been done, but we were only able to capture patients that had a neobladder and those who had an ileal conduit. Our numbers were quite high. We had 22 patients with equal numbers in both groups. And throughout that qualitative research, we came up with various themes that were identified based on patient feedback. And one of the themes that came out through the study was the theme of incontinence. And so urinary incontinence or leakage from a pouching system was a frustrating and challenging problem for the participants that were in the study. And several strategies or different ways of dealing and coping with the situation were tried by individuals, often on their own initiative. And this was particularly striking for those that did not live within the Sunnybrook area. And so people that live outside of the GTA were finding that they didn't have access to the resources that they needed to help them troubleshoot with the problems with leakage. And whenever you do qualitative research in terms of looking at the themes, we also want to get the patient's feedback. And some of the quotes that came out was that you don't want to go around wetting your pants for the rest of your life. So that was, but you don't want to die either. So you kind of go in with an open, there's lots of pros and cons. I don't remember ever for a second, considering not going through any of this. And this was a patient who had experienced incontinence but had a neobladder procedure. Another patient with the neobladder procedure said, I'm not happy walking around with a pad all day. I thought those days were over. And for a patient who had an ileal conduit, a female patient, 73, I couldn't do anything, I bought all my pants, they were black pants, so that if I started leaking, it didn't show until, I got home. And so very striking points that if the procedure works well and you're not having any problems with leakage, everybody's happy. But if you're in a situation where you do have problems with incontinence or leaking from a pouch or leaking from a site that you're going to catheterize, it becomes very problematic. Now, Dr. Raj, as we refer to him at Sunnybrook, did walk through the different types of urinary diversion procedures, and I think he did a great job. And so what I'm going to do now is just briefly touch upon what are some of the issues that people can have. And certainly, again, at the end, if there's time, I'll entertain some questions. So for the patient that has, sometimes we refer to this as an Indiana pouch, or basically having your bladder removed and a little stoma made that you can actually catheterize through to get the urine out, there can be occasional problems with leakage. So you can get leakage from the actual stoma site, and you can see a little bit of urine seeping from this very small little opening. And so why can this happen? And I've tried to break it down in these ways for you. Waiting too long to put your catheter in, you're having difficulty putting the catheter in, or there could be problems with the little valve mechanism that is keeping you dry internally that has been created by the surgeon. So if you wait too long to catheterize yourself, And this seems to be more of a problem in the first few weeks after surgery. I would say a month to possibly 2 months. So if you're leaking in between, you're often waiting too long to put the catheter in. And you don't want to have leakage with this, okay? This is designed to keep you dry. So you need to think about increasing the frequencies for which you're putting the catheter in to drain the new bladder. You want to catheterize yourself before you're engaging in different activities, just like you would have done in the past in terms of toileting. And you should always carry catheter supplies with you wherever you go, so that if you do have to catheterize, you are able to do so. Now, another reason you might have problems with leakage is difficulty putting the catheter in. And one of the complications that can happen with this procedure is that the tract can actually get smaller, or what we might say stenose, so that you're having difficulty getting the catheter in. And sometimes you might have started off with a catheter that was a diameter we might call a 14 French, and you may have to decrease the size of the catheter to get through into the new bladder. So you want to make sure that you're lubricating that catheter well. Maybe it's a little bit too dry and it can't get through. You also want to think about readjusting the angle that you're putting the catheter in, or maybe your position, because sometimes that can alter the ease with which to put the tube inside. And sometimes you might be a little tense. So if you're having difficulty getting the tube in, you're going to get tense. You need to think about some relaxation strategies that may help to open up that tract. And the other thing is that with these procedures, whether it's the neobladder or the Indiana, because more bowel is being used, there can be an increased production of mucus. And this happens with ileal conduits as well. That mucus does decrease with time, but perhaps you've got some mucus that's plugging the tract. And so we will teach patients to flush that area or into the bladder to remove mucus with about 30 to 50 mils of saline. And finally, you may have a problem with that little valve mechanism that's keeping you dry. So think of it as a one-way, for those that don't have this, but it's like a one-way valve. If you push the tube in, you're opening up the door. You're getting that opening so that you can get the urine out of the reservoir. So if this happens, you're going to have constant leakage of urine, and that's very troubling for patients. So you want to make sure that you're protecting your skin, and that would be using a barrier wipe or an ointment or cream, because the urine can be quite caustic on the skin. You may have to consider putting an ostomy pouch on to collect the urine. And Dr. Raj mentioned that sometimes when we do these catheterizable stomas, we're making the opening in the belly button or the umbilicus. And so when I mark people for surgery, I sometimes will mark in the right lower quadrant, so sort of that space between the belly button and your hip, because if you do have a problem with leakage, it's usually a flatter area, because many people have different contours around the umbilicus, around the belly button, that can make it difficult to put a pouching system on. And the main thing is to contact the urologist. So for patients with catheterizable stomas, I do a lot of teaching up front to help people with decision making about which type of diversion would be better for them and their quality of life and their lifestyle. But when there are problems afterwards, often it's to the urologist. So I wanted you to know of some strategies, but usually you're having your follow-up with the urologist. Now, when we get to the ileal conduit, Dr. Raj talked about this as well, and this is a very common procedure, and he talked about the different types of cars, and I think we're probably talking about maybe the same surgeon. When I started here 14 years ago, it was the Ford versus the Cadillac, so the cars have changed, but it's still going with the simple versus the more complex procedure. So with these patients, I'm going to show you some pictures. And this is the group that I follow very closely, and some of you in the room I have seen you in follow-up. And so I have to tell you, some of the slides are a bit graphic, and it doesn't mean that these things always happen. And the reason I'm talking about the complications with the conduit is that we know that people from studies are often having problems with leakage, problems with their skin, and they don't know who to call, or they don't seek help, or they think that it's part of something that they need to live with, and you don't. So why can we have leakage from a urostomy? So I've listed the different reasons that can happen, and we're going to talk about each of these individually. But you can have a change in the stoma size, a change in the condition of the stoma, or your skin around the stoma. You may have a skin infection that's developed, or you can have changes in the contour of the skin. And people lose weight, gain weight over time, and these can certainly impact the ability of the product to adhere well to the skin and then result in leakage. So if we take all of these individually, one of the things that we know when there's a stoma made is that the size can change, and that usually happens in the first 6 to 8 weeks after surgery. But I see a lot of people coming back to the clinic and they say, I'm leaking all the time. And it's because they're changing the appliance lying down, they're not remeasuring the stoma, because if you gain weight, your contour changes, you may have to alter the size of the opening that you're cutting in the back of the barrier or the product that goes on your skin. So the thing I want to leave you with is that if you're having leakage, always double check the size of your stoma. And this can happen periodically, but you want to make sure that you're assessing that change in the size sitting and standing, because usually when you're flat, the stoma may be a little bit smaller. And you want to cut the opening that's almost the same size as the stoma. Now, changes in the stoma condition. So we all want to, for those with a urostomy, have it so that the stoma is sticking out from the skin. That reduces the chance of you having leakage underneath a product. But the stoma can change. So if you look at the middle picture, you may have a stoma that once was sticking out a little bit. It's now sticking out maybe 2 inches instead of a ½ inch. Or you may have a stoma that's referred to as retracted, where you're going, where is the stoma? It's no longer sticking out. Or maybe that's how it was made at the time of your surgery. So if the stoma is changing, that can contribute to leakage. And again, looking at the stoma in the sitting and standing position is critical, because that's when changes can occur. There also can be the importance of, if you've got a little crease around the stoma, you need to flatten your skin, again, in order to really see what is the size and what is the shape. And you're going to see with all of these slides that these are the types of situations to come and make an appointment with me if you're a patient from Sunnybrook, or with your ET nurse from the hospital where you had your surgery. Because there's often more than one thing that is going on that can be contributing to leakage. And the ideal wear time for me, I would say, would be if you're not getting 3 to 4 days with a pouch staying on your skin, you need to seek out some assistance and see what is going on. So what about skin infections? So we would say that people who have a urinary diversion and have a conduit, that there's no risk of infection. We're cleaning this little opening just with tap water, nothing special. But if you end up getting leakage, meaning that maybe the product's not falling off your skin, but the urine's getting trapped underneath between the barrier and your skin, it's a warm space. And what's typical with people with urostomies is that they can get what we call yeast or candidiasis. You get very red, itchy skin, and the little rash can spread beyond where the product is sitting on your skin. And this is a typical picture of what yeast looks like. When it gets bad, the skin gets very wet. So that also contributes to leakage, because the product or the barrier can't adhere to something that's moist. So you need to be seen, because there's different rashes that you can get that may not be a yeast infection. But if it truly is believed to be a yeast infection, you need an antifungal powder. Not creams or ointments, because that'll prevent the product from sticking on, but you need to get an antifungal powder. You need to think about increasing the frequency of changing the product. Some people leak because they can keep their product on for a week, but if the barrier is wet on the back, a week is too long. You're trapping the moisture, it can lead to getting an infection. Having a product that's got an extended wear barrier, a product that absorbs moisture, again, is something that's very effective for urostomies. And so you may not know what are the ingredients in the product that you're using. Again, going to see the ET nurse is going to help you to decide, do you actually have the right product? So you can see arranging an ET nurse visit is critical in order to help problem solve and figure out what is going on. So these pictures are showing changes in the condition of the skin. And I found when I've done some talks before, just showing the picture, maybe not going through all the strategies, is helpful for you to say, this does not look normal. The skin around a stoma should always look like the rest of the skin on the abdomen. If there's redness, open skin, rash, grayness, that is not normal. So the picture that is labeled pseudoverrucous lesions, don't worry about the title, it's a clinical diagnosis. You can see that the stoma is not sticking out in that picture, and that the skin around is kind of a gray color and it's very rough. If you've ever put your hands or feet in water for a long time, you want to soak your feet. What happens? The skin gets very thick. So the picture with the pseudoverrucous lesions is an example when you're getting a buildup of urine underneath the product that is not getting absorbed. And so that moisture buildup on the skin causes the skin to get thick. And what can happen over time is you almost get these little warty-like lesions, a very uneven skin surface. It makes it very difficult for the product to adhere to the skin, and then you start having some leakage issues. So something very important, if you see this, you want to seek some attention. Sometimes you may get a little wound next to the stoma. It's a pressure ulcer. And you can see in the bottom picture that being identified on your right around the 2 o'clock position. And so this can happen for a variety of reasons, but if you end up with a wound next to the stoma, it can open up and be wet. When you have a wet surface, it can affect your product adhering, and so that leads to leakage. So you need to get that assessed. You need to figure out why did that wound happen, and we need to basically treat it with wound care products to again absorb the drainage, create a dry surface, and help your product adhere on the skin. Sometimes people can get a change in the contour of the skin because of a hernia. And so if you have a bulge on your skin, you're going to notice it when you sit or stand, and it may go flat when you lie down. When this happens, if you think of something that is stretching, your skin stretches. And as your skin stretches, the stoma size is going to change shape and size. And so I see a lot of people, not a lot, I don't want to scare you off thinking maybe I shouldn't have had a urinary diversion, because this does work well for a lot of people. But this is really important because there's things that we can figure out by just looking and assessing and saying, you know what, we need to get you a larger barrier. We need to make sure that you're changing this and measuring when you're standing up. And that can be all that's needed to increase the wear time of a product to perhaps back up to a week. So just wanted you to see some of the different appearances that can happen on the skin. And again, it's important to go and see the ET nurse. If you develop a rash on your skin, I mentioned that that's not normal. You can see that in the top picture, allergic contact dermatitis, there's this very red, angry area. And this could be an allergy to the product that you're wearing on your skin. So if it gets irritated and you get a severe dermatitis, the skin's going to get open and moist, again, impacting your wear time, getting leakage issues. You want to go in and figure out, do I need to change my product? Also, what are you putting on your skin that may have caused the skin to get irritated? And then the last example I'm going to show you is if you have a situation where perhaps you've gained weight, and you can see with this person sitting, you can't see their stoma. Now, the product was being changed in this case with the person lying down. So whenever they stood up, the skin contour changed, this fold appeared, and what we needed to do was to clearly get a product that would help to keep that little fat fold away, something with a bump on the back of it, and the patient's wear time went from daily leakage up to a week. So you can see that if you're having leakage, that we do have some redness around that little stoma, and it was actually spreading over towards the post-op incision. And again, warm, moist environment, not only are we having problems with the product adhering because we don't have the right type of product, we're also going to be increasing the risk of this person getting a yeast infection. So that was just to give you an idea. The bottom line of that last presentation for those in the room with the urostomy, if you're not getting a wear time, I'm going to say a minimum of 3 to 4 days, your skin is not looking normal, you're having problems with products staying on, please contact your ET nurse so that you can be assessed. So we're going to switch gears now and talk about the neobladder. And I just want to say that with this group of patients, we're going to talk about some leakage, and Dr. Raj spoke about that. This is a group of patients that I do not routinely follow, although I did work and run a continence clinic for 3 years before I came to Sunnybrook. And so I'm going to share with you strategies that many of you may have tried, and maybe incontinence has not been an issue for you. But some of the strategies we're going to talk about will also help other people in the room who actually have some urinary incontinence. So I'm not going to ask if you do have any little stress urgency incontinence, but these are strategies that will be helpful. So the thing with the neobladder is that you can have leakage, and this is something that can actually take time to improve. The literature varies in terms of saying it could be a few months up to a year. What has been stated in the evidence as well is that the leakage for people having a neobladder resolves sooner during daytime when you're awake and aware of your toileting habits versus when you're sleeping at night, and so that some people will experience more what we call nocturnal incontinence. So why can this happen? waiting too long to empty the new bladder, not emptying the new bladder completely, and weakened pelvic floor muscles. So what are we going to do about this? So in the beginning, for people who've had neobladders, it again will take probably a month to 6 weeks or so, where people are toileting regularly and then gradually increasing the time frame between toileting. But you need to know your body, you need to look at how much fluid you're drinking, and if you're waiting too long, you need to find out when is the trigger that you tend to have the leak. So are you having leakage issues at 3.5 hour mark? And if so, you probably need to toilet or go to the washroom every 3 hours. So try and figure out when is the point where you get overdistended and you need to empty the new bladder. So what are those leakage points? And think about increasing the frequency of toileting. And if you're having leakage at night, that hopefully after about 5-6 weeks you're able to sleep through the night without leaking, you may need to set a clock to wake you up at night in order to toilet so that you're not having a leakage episode. So another problem with this can be that you're not emptying the reservoir completely, and Dr. Raj talked about the fact that standing up to pee, for example, for men may not be what you're able to do after having a neobladder. And so many people have to sit because before, your bladder has a muscle and it contracts and the urethra relaxes so you're able to empty. But when you have the new bladder, it's not working like the old. There's no muscle there. So sitting down to urinate is often an effective strategy to emptying the bladder. You also need to tighten the abdominal muscles. It's almost like bearing down so that the abdominal muscles press on that new bladder to push the urine out effectively. And if you're going to push the urine out, you need the muscles in the pelvic floor to relax. Otherwise, you kind of have two forces going against one another. So again, if you're feeling like you can't empty, you need to make sure that you're not tense and try and do some relaxation. And there's a technique called double voiding, which means if you sit down to pass the urine, stand up, and then sit back down again. Because there may have been a little bit of urine that by doing those changes in position, you may be able to empty. And Dr. Raj mentioned that for some people, if they can't empty, they may need to have to catheterize. So sometimes if you're pooling a lot of urine in the new bladder, it could be overwhelmed and you could leak. And so maybe the strategy is we have to put a catheter in every once in a while if there is what we call a retention or a holding of the urine. Again, if you're having significant issues, it's good to, if you're not getting the urine out, to talk to the urologist and to have a cystoscopy or a bladder scan to see if you are keeping urine in. So the other thing we're going to talk about at the end is about pelvic floor muscles, and we're going to do a little exercise, so I'm going to come back to this. But we can have weakened pelvic floor muscles, and Dr. Raj mentioned too that in men, for example, the prostate's coming out, you do have sphincter mechanisms in that prostatic urethra that is lost at the time of surgery, and so that's why leakage can become an issue. So you want to think about, are you able to learn and to do pelvic floor muscle exercises? So I'm going to come back to this slide so we can actually do some practice to wake you up. And there are ET nurses, continence advisors, and sometimes physiotherapists that can be very effective in helping to retrain that pelvic floor. So additional strategies to think about, and again, many of you may have tried these, is to really think about your fluid intake and the impact that it has on that new bladder filling up. If you tend to have a lot of leakage at night, you're going to think about limiting the fluid that you have before you go to bed. If you are having leakage, think about, again, the damage that the urine can do to the skin around the urethra. So you want to be thinking about any type of barrier ointments or creams that you could use. And if you're finding that the reason you're leaking is that it's taking a while to get to the washroom, then think about other aids that you might be able to use, like having a urinal close by or a raised toilet seat, something that might facilitate your urination at home. This is more of a challenge when you're going out, but again, some things to think about. And the other thing, and this is probably more of an issue at the beginning, is modify your clothing. So if you feel like you've got the urge and you need to empty, but you're struggling to get a belt undone or a button undone, think about Velcro, think about elastic waistbands, something that's going to make it very easy for you to remove your clothing and facilitate emptying the new bladder. Continent products are very, very important. I'm not going to go through all of these, but what you may be using at the beginning, if there's a lot of leakage, over time should come down to a very light pad. because the amount of drainage or leakage is hopefully improving. The other thing you want to know is that you want to use incontinent products, okay, at Tens, Depends, Tens, lots of products on the market, not a pad that is used for menstruation, because it does not wick the urine in, and you end up having a lot of products you're going through. It gets very cost prohibitive, but it's not going to protect your skin. So you want that sort of diaper technology that's going to really wick the fluid in and keep you dry. So I'm going to come back because we have a couple minutes. We're going to do some pelvic floor exercises, okay? So this was just to give you a little bit of a snippet, and then if we have time, we'll do some question and answers. And I will be here at the end. But this is not easy to do. So how many people do Kegel exercises? Okay, how many have heard of Kegel exercises? How many have tried them? How many have not tried them? They're not easy to do. I'm going to tell you, if you're going to try them, the best way to start is when you're lying flat on your back. Okay? Then, as you get really good at doing your Kegel exercises, strengthening the pelvic floor, you can sit and then progress to standing. So I could be standing back here doing a Kegel exercise right now, and you would have no idea I'm doing it. Or you might do it on your way home on the bus or in your car. So here's what we're going to do. We're all going to get a comfortable position. I want you to put your feet flat on the floor. The way that I used to teach this was to actually put your hands on your abdomen. You might put one on your abdomen and one on a thigh, okay, on your thigh. So abdomen, thigh, because you don't want to tighten these muscles. Because if you tighten these muscles, you're pushing down, and that can contribute to leakage. So you've got to be relaxed. That's why starting out lying on your back is a good way to learn these. So what you want to do is think about stopping gas. Okay, everybody knows, I'm sure you've tried this. You may choose not to, but you all know how to stop gas. It's not about thinking I'm going to stop urinating midway through my stream. That's not a good habit to get into. But you want to think about tightening the anal sphincter mechanism. So what I want you to do is think about stopping gas and just hold the contraction for 3 seconds. So tighten your bum, your bottom, and hold. 1, 2, 3, relax. 2, 3. Okay, tighten. 2, 3, relax. 2, 3. How many felt their abdomen getting tight? How many felt their thigh getting tight? You may be tensing up a little bit, but that's the technique to learning Kegels. Okay, so practicing that can be a very effective strategy to help tighten the pelvic floor. So you want to start off holding the contractions for 3 seconds, because if you pick up a tear-off sheet and it says 10, you'll get very frustrated if you hold it for 1. So start off with 3-second holds, 3 seconds to relax, because you're going to get tired. It's like doing arm exercises, and you're going to do that 10 times, and that's a set. And you're going to try that 3 to 5 times a day. Now, what you want to think about for those, if anybody's had a fresh neobladder, is to talk to your urologist, because they may recommend that you don't start doing those exercises until at least 6 weeks after the operation. Okay? So that's something you can practice moving forward, whether you've had a urinary diversion or not. It's something that's helpful for everybody, but they are not easy to do. So as I say, start off flat and then work your way up. So I'm going to close by saying that this was just a snippet of some of the issues that can happen if you have a urinary diversion. And I want to go back to the study that I talked about that we did. After we went through and looked at our themes from those 22 patients, 11 with the conduit and 11 having the neobladder, we did pull some of the participants together so that we could share with them what our research findings were, and to validate that what we felt was what we were finding was in fact the case, and there was agreement with that. When we got the two groups together, guess what happened? There was a little bit of discussion about whose type of diversion was better. And what I want to tell you is that it's a very individualized choice. And Dr. Raj mentioned that. And so when I see people, and again, I'm not following people with neobladders at Sunnybrook because there's no stoma, but I do meet a lot of people where it's been determined by the urologist that you may be a candidate for all 3 types of diversions. And it's important to make sure, and I will spend an hour with patients going through what the 3 different types of diversions are, what is the impact on your life, what is the care that's going to be required to manage that urinary diversion as you go throughout your life, And for the patient and the family, particularly the patient, to decide for them what is the best option for you. Now, when we do that, we will have patients where everybody might say, well, I don't want to have a stoma. I don't want to have any of those complications I just saw on the screen. It's interesting when I've met with patients, the thought that maybe you would be best with a neobladder is not what the patient chooses. They don't want to have issues with incontinence. They don't want to have to wear pads. They would rather have a pouching system on that they can just empty and maybe connect to a night bag when they're sleeping. But there's other people that would want to take that risk because they don't want to have a stoma. And for those with catheterizable stomas, they work great. You have a little bandage that goes on your skin. But I've had patients that have said, I do not want to put a tube into myself. I think it's going to hurt. I don't want that. I don't want to clean catheters. So what I'm saying is that whatever choice was made, that you made, is the right one for you. Okay? Everybody is different. So this study, although it's old, I think pulls it all together. Patient satisfaction depends on the anticipated results, what you think is going to happen, which are largely a function of informed consent and realistic preparation by the clinician and the intrastomal therapy nurse in explaining before surgery the physical and lifestyle changes that will result from a urinary diversion. And I'm at the end.